Mode.
Hi, welcome everybody. Welcome to our Brown Bag Lunch training series. This is a training series on health and policy topics affecting children and youth with special health care needs. Our presentations are typically geared towards families, professionals, parent-to-parent staff, youth, and anyone else who would be interested. Today's topic is on nutrition, eating, pooping, and growing with Hope Willis from USC USED. She's also the director of the Dietetic Internship. I hope I said that right, Hope. A few notes about the technology for everybody listening. Unless you're absolutely sure that you have a headset with a microphone that you can speak through using your computer, you'll need to either call in or type in your questions. So you can find the call-in number from your confirmation email, or while you're connected, you can go to the audio menu, select Use Telephone, and it'll provide you with a dial tone, access code, and audio pin. And remember to enter the audio pin. And if you have any additional technical problems, you can either call GoToWebinar at 1-800-263-6317, or you can send me, Tara Robinson, a chat or a question. And generally, we have everybody on mute at the beginning because of feedback issues. So when you'd like to ask a question, you can just select the hand icon in the control panel. It's on the small column to the left of the menu. It's a little hand with an arrow. And if you click that, we know you want to be unmuted and have a comment or a question. And if you ever have trouble getting heard, you can always submit a question by chatting or typing it in. And there will be time for questions at the end of Hope's presentation. So we're going to ask you to write down your questions as you go and either raise your hand to be unmuted later or send a question in by typing it. And lastly, we will definitely email everybody a copy of today's presentation. And with that, I will go ahead and turn it over to Hope and we can get started.
Okay, well, good afternoon, and thanks so much for inviting me. I had occasion to speak with Ms. Landry probably 2 months ago, and she said, what do you think is something that affects a lot of families that you encounter? And I'd say there's not a day that goes by that I don't spend probably an hour or two talking about pooping. It's something that we all do. It's something that's very important in maintaining our health, and if we can't do it, we're pretty uncomfortable, in fact, sometimes even miserable. So we decided that I would focus today on problems surrounding constipation and how that can affect a child's growth and nutrition, and think about some ways that we can manage it either through diet or maybe through some alternative methods, and to have a discussion about some strategies that we can use to support our children. So these are the objectives of the presentation. So to discuss the impact of nutrition on health and nutrition, to discuss some dietary and behavioral strategies, and to discuss the pros and cons of some traditional versus non-traditional management. So my first question would be, is it constipation? For example, when a baby makes a face, when they really, really have to poop, we've all seen that look of intense concentration. Does that mean a baby's constipated? I've had parents come to me and say, oh, my child has, stool. He poops every day, but it looks like goat turds. Is that constipation? And then I have questions about, well, my child only goes to the bathroom every other day or every third day, but he's not straining, he's not in pain. Is that constipation? And even still, in some of the older children, I have parents tell me I can tell when my child is going to have a bowel movement because he gets really cranky and really irritable. And the question is, could he be constipated? So first I wanted to review what is the definition of constipation, and this comes from the American Academy of Pediatrics. So for children, the definition is infrequent and often incomplete elimination of stool. And I just wanted to emphasize the point about incomplete, because we know that sometimes our children are in a hurry. There's the show that they want to watch, there's the, They want to go outside and play, so instead of having a nice long sit and finishing their business, they get up halfway and run out. And also the presence of hard and painful stools. So in the slide prior, I said if a kid is having, really, hard goat turd stools, even if they're having them every day, that would still be considered constipation. Constipation, some basic facts, it affects up to 10% of all children experience some kind of symptom related to constipation. And in the population that I work with, which are children with special health care needs, the rate can go up as high as 50%. And in fact, in some of the more recent literature on autism and gastrointestinal disorders, some parents are reporting out at as much as 65% of their children are being affected with constipation. The main site that's affected when we're talking about constipation is the colon, which is the last segment of the large intestine. And the role of the colon is to absorb water from the contents in the intestine. So I don't know if anyone's eating lunch right now, but if we were to envision pea soup, that's basically what the chyme or bolus looks like when it's in our small intestine, kind of like pea soup. And so by the time it reaches our large intestine, it's still quite watery. The role of the large intestine, or the colon, is to absorb or reabsorb water from that soupy mixture so that we have a more formed stool. The key point here is that the longer the stool stays in the colon, the harder and drier it gets, because that's the role of the colon, is to absorb the water. So the longer it stays there, the more opportunity it has to draw water out of the stool. Another key thing to remember is that the large intestine is made up of smooth muscle, which is very elastic in its nature. So it can stretch and stretch and stretch, and what typically happens is after it stretches for a while, it contracts. And that's the type of movement that helps to move the food through our system. If we think about a rubber band or even a balloon that gets stretched out over and over and over again to the limits of its ability to tolerate it, it's never quite the same shape afterwards. It loses its elasticity. And so that's one of the physiologic effects, or actually anatomical. It actually affects how the body is able to work from extensive and chronic constipation. Now here's a concept that's relatively new. We always knew that the gastrointestinal system, your intestines, they're smooth muscles, which means that they have to be innervated or activated by the nervous system. And that nervous system is called, part of it is called the mesenteric plexus, and a word we don't need to think about any longer. But think about it as the center of your gut nervous system. And this nervous system can operate separately from your central nervous system. So your central nervous system operates your body, your brain, your skeletal muscle. It helps you to walk and move, and it helps you to coordinate things inside of your body. And at times, what can happen is there can be a lack of coordination between the gut nervous system and the central nervous system, and that causes a slowing down or a breakdown in communication, which means that your guts, your intestines, are not working optimally. And so that could be part of the problem with constipation. Not just that there's a lack of movement or slow movement, but that the movements can be uncoordinated and not moving in a smooth sequence. Some of the main causes of constipation, especially in children, are related to muscle tone. And like I said, it could be low muscle tone, meaning the muscles are weak and not able to fully participate in elimination, or it could be poor coordination of muscles. Mobility, the ability to walk, crawl, roll around, can impact the ability to eliminate and cause constipation. Diet, absolutely. Hydration status, how well we have consumed fluids throughout the day. And even hormonal regulation, where children who suffer from hypothyroidism have a higher incidence of constipation. And even females, we see an increase in constipation during pregnancy. We see an increase in constipation as it relates to premenstrual syndrome. So we even see a hormonal influence in constipation across different ages and genders. Now, this is a very interesting study that someone forwarded to me from the Journal of Child Care. And they looked at children across a variety of abilities. And these were all pre-adolescent children, only 84. But out of these 84 children, 33% experienced constipation or symptoms related to it. That's pretty high compared to what's typically reported in the literature. And then when they tried to look at what were some of the factors that influenced this constipation, they found that children with higher intakes of water and fiber had less constipation than children who consumed less. But it really wasn't an astounding difference. It was a little bit of a difference. And even more surprising, they found that children with higher levels of activity experience more constipation than children with lower levels of activity. And that was definitely a surprising finding, because you would expect that children who move less would have more issues with constipation. One of the explanations for that finding was that maybe children who were more active experienced a relative level of dehydration. They were so busy running around that they weren't drinking enough water, and maybe that contributed to higher rates of constipation in that group. So this is part of a very vicious cycle where if a child is experiencing painful pooping, they will avoid it, right? They'll find ways not to do it. They'll hold it. They'll go run outside and play. They'll lay on their tummy. They do lots of things to avoid the process, which leads to constipation, right? Things get blocked up. And then the stool stays longer in the large intestine. It becomes harder and drier, which means now we have more painful pooping and more avoidance. So it's something that if you don't intervene, can snowball on you and on the child. From a nutrition perspective, and that's the hat I wear 90% of the time, I see the impact of constipation on children's appetites. When you're full of poop, you're not hungry. And so parents will report, oh, he ate really good for 2 or 3 days, and then the last 2 days he didn't eat very much. And then I'll ask them, well, when was the last time you had a bowel movement? Oh, just about 3 days ago. Sometimes children will associate foods with discomfort. So they know that when they eat this food or eat these kinds of foods, they get uncomfortable, they get gassy, they get bloated, and so they will avoid that food. Again, resulting in diminished intake. And then also, the longer the stool stays in the gut, the more opportunity for gas formation. And so sometimes my people have these really swollen tummies, and they're so hard it's like a drum. And again, you know, if you've got all that gas in your tummy, you're not feeling like eating, you're not feeling comfortable, And so again, we see the diminished appetite and intake. We also see changes in the child's behavior. We can see increased irritability, crying. I personally have had children, go into quiet corners of the room and just sit there rocking because their stomach hurts. Some children will actively avoid going towards the restroom, or children who are non-ambulatory will get into positions where they're not able to push, they're not able to facilitate a bowel movement simply because they don't want that pain. And so parents often ask me, what can I do about this? What can I do to make this situation better? And most experts recommend trying dietary intervention before trying any other kinds of intervention. And one of the first interventions is fluid, because fluid helps us to keep the stool soft and improve passage of stool. Now, a fluid is anything that can become liquid at room temperature. So that opens up, the box for a lot of things. Most times when we think about fluid, we think about water, which is always a good choice for many children. But we can also think about Jell-O as an opportunity to improve more fluid. Juices, in particular, some of my favorites are prune and pear and apple juice. And then another way to improve the fluid intake is to try to use foods that contain a lot of water. So things like berries, melons, juicy fruits. Right now, in the market that I shop at, we have a lot of peaches. They're just delicious and juicy and a great way to add more fluid. And then another way is to try to add some blended fruits, especially the watery kinds, to some of the foods that the children are eating as a way of increasing the fluid intake. So we often focus on water, but there's lots of other ways to get the job done. We can also focus, when we're talking about dietary intervention, on increasing fiber intake. And this is probably where I spend a good amount of time talking with families. Of course, we have some of the traditional ones like vegetables, which for some of my clients are a really hard sell, fruits, cereals, whole grain products, and some of the fiber supplements. But when we talk about fiber, we have to think about what kinds of fiber are we pointing towards. Are we talking about insoluble types of fiber or soluble types of fiber? And they have different roles. For insoluble fiber, it's primarily the indigestible portion of a fruit or a vegetable or a grain, and it really provides bulk, helping to move food along the GI tract. Again, some of the food sources that we have down there, whole wheat products, Corn Bran, makes great corn muffins, by the way. Now, soluble fiber is a little bit different. It's water soluble, and it allows the substance to form a little bit of a gel-like mixture in your stomach or in your system. And it also has an ability to bind up some of the fatty acids. Hence, we see the commercials for Cheerios and lowering of cholesterol. Even though Oat Bran has a wonderful track record with lowering cholesterol, you have to eat a lot of Cheerios to get that kind of effect. But some of the food sources of soluble fiber are things like beans or legumes. Those are excellent sources of soluble fiber. Vegetables like okra, squash, and gourds, spaghetti squash, banana nut squash, those type of gourds are also excellent sources of soluble fiber. And the reason why I make the distinction between these two fiber sources is that the soluble fiber absorbs water that's in your system, and with the insoluble fiber, you have to add water to your system. So these are some of the typical fiber supplements that you see out in the community and in the stores. For example, there's Metamucil, there's Citrusel, and even Fibercon, and these represent forms of insoluble fibers. And again, you need to add water in order for these fiber supplements to do their job. If you simply just try to use the minimal amount of water or fluid, what you end up doing is creating concrete that is very difficult to eliminate. Now, Benefiber is one of the newer fiber supplements and this particular version is targeted towards children, and they have a blend of both soluble and insoluble fibers. So I often encourage parents to look at a mixture of fibers rather than concentrating on one particular kind of fiber supplement, just because that fluid component is so important. And if you have a child who is, I don't want to say picky, but a child who is difficult, even that doesn't sound very nice, a child who's challenging when it comes to consuming adequate liquids, the insoluble fiber supplements like Metamucil or Citrusel may actually cause you more grief than provide benefit for the child. So the question that parents often ask me is, how much fiber are we talking about? And the recommendation for children is their age plus 5 grams a day. So for a child who's 5 years old, the expected fiber intake would be roughly 10 grams per day. Whereas for adults, and for adults I'll include adolescents, starting at age maybe 14 to 16, we're looking at intakes of 25 to 35 grams per day, with men usually requiring a higher amount compared to women, and with a recommendation for more insoluble than soluble fiber. And I'm not 100% sure if that's really a recommendation as much as it is an observation that most people tend to consume more insoluble than soluble. So I don't know that I would call that a recommendation. In fact, I won't. I will call that an observation that people tend to eat that fiber in that kind of relationship. And then we come down to the really hard part. The really hard part are some of the behavioral interventions and strategies that families may need to employ. Now, in the environment that I work with children who have a variety of cognitive levels. Some of my children are very impaired, and some of my clients are just moderately so. So we really have to tailor our strategies to what my clients are able to access and employ successfully. But one thing that I encourage parents to do often, and this is about their own behavior, is to mark the time. Many are the times where I've asked parents to look at, when the child is having a bowel movement and when their appetite is good and when it's not. And they've come back to me and said, wow, I've had no idea that it was having that much of an impact, where they could see on the calendar that after the second day of not having a BM, that their child's appetite diminished substantially. So that's just one thing that's an easy thing to do, to just mark on the calendar when a child has a bowel movement, so you're not having to try to remember, was it yesterday, the day before yesterday, or has it been 3 or 4 days? Although I'm sure by that time your child has let you know that they are pretty uncomfortable. Another behavioral strategy is making time. We always laugh when we think about the police officer or the bus drivers, going to the bathroom with the newspaper for his daily constitutional. We laugh because we've known people like that. Maybe we've even been that person. And so we know the importance of providing time and a regularly scheduled time to relax and to, have a bowel movement. So making time and scheduling that event at regular times during the day, maybe, right before nap time. They always go to sit on the potty, or right before dinner or after dinner. Everybody's body rhythm is different, but having those scheduled times can really make a difference for children as well as for older or young adults. And then another part to the behavioral intervention is relaxation. If a child has been experiencing pain and discomfort when they're having a bowel movement, then now this experience has become stressful. And it's really, really hard to let things pass through your body when you're tensed up waiting for the pain to start. So looking for ways to help the child relax before taking them to the restroom, if indeed that's how they eliminate. Some of my clients eliminate using a diaper. But finding ways to help them relax, whether it's through reading stories, listening to music. I've had many parents tell me, oh yes, I turn on his favorite music, I give him a bath, I rub him down with some baby oil, and then, he's able to give me a bowel movement. So each child is different, and for those of you out there who are parents, you know your child better than I do, or I ever will for that matter. So you know what's going to help them relax and move past their fear and their apprehension. Movement and massage can often help. I've seen therapists, physical therapists, and occupational therapists move a child's lower extremities using the bicycle, or using tummy time, having them push up and roll over as a way of helping to massage the abdomen and help move the food through the system. And then infant massage for some of the children that I work with who have been discharged from the NICU or from other kinds of long-term facilities where they've been cared for. Doing very gentle massage through the muscles and through the abdominal wall really can help move the food down. And there are several programs. I'm down in the LA area right now that offer infant massage, and the parents have reported to me that in addition to the well-being they have for touching their child, they're seeing more regular elimination, less crying around elimination, and I think that's always a good thing. Now, some of the non-traditional treatments that I've seen for children who are experiencing constipation, some of the herbal remedies that are out there. One in particular is Senecot, which is an herbal. I mean, it's derived from a plant, and it's got very strong properties and help with elimination by increasing the motility of the gut and the large bowel. Some of my clients are involved with craniosacral massage, which they believe help their child have better elimination. There are some anecdotal reports at this point in time that support the use of craniosacral therapy for the management of constipation, but there haven't been any clinical trials comparing craniosacral therapy with any of the other types of therapies that are available for constipation. So hopefully that's coming down the pike. And then we also talked about the abdominal massage. I have seen the effectiveness of this in children, particularly in infants when the parents have participated in courses in infant massage. I often hear from my clients about teas. One in particular is sassafras tea, which has a slightly licorice taste to it. There are multiple reports of the successful use of sassafras tea to help with elimination, but I often caution parents on the use of sassafras tea because it can interfere with several anti-seizure medications, in particular valproic acid or Depakote. It can interfere with the body's ability to metabolize that medication, and so I caution parents about that one because it can just impact other parts of the child's care. Senna, I mentioned that earlier. It's a product that's used pretty widely around the world. I think it came to us a little bit late. Not sure about that. There are several teas out there that use this senna leaf. One is called Smooth Move. Another one is called Morning Thunder, although I don't know if that one's still on the market, and I'm not sure if I would use that in kids. But the Smooth Move tea, the foundation is senna, and it does help to promote elimination in children as well as adults. You do have to be careful with the quantity that you start with because it is quite potent. So if you start using really large quantities straight out, you can end up with a little bit more poop than you hoped for. In terms of constipation and how to treat it and manage it, some of the concerns that parents bring to me are, will my child ever be able to have a bowel movement independently? Are they always going to be dependent on some outside assistance to have a bowel movement? And the answer for many of my clients is yes, they will typically need assistance for the majority of their lives. And it's a hard thing to have to say to a parent because I don't want to say it. But when I think about what we spoke about earlier with the elasticity that gets lost with prolonged and chronic stretching of the smooth muscle of the large bowel, the colon, if you keep doing that over and over again, then there's no opportunity truly for the body to ever learn how to operate independently. So using interventions, whether it's fiber or using medications or even herbal products or massage, using those kinds of tools to help help a child have regular elimination, you're actually allowing the body a chance to heal itself and possibly in the future be ready to do these things on their own. But if it's constantly stretched out, if it's constantly irritated, then you are reducing that opportunity. Another question often brought to me with parents is that is there any interference? Does being constipated interfere with the ability to absorb nutrients? And at this point, I would have to say no, that there's no interference with the ability to absorb nutrients, except, as mentioned earlier, when a child is constipated, their appetite goes down, and so their ability to absorb nutrients, although not impaired, is reduced because they're eating less because they're full of poop. So we sometimes are reluctant, and I'll say that as a parent, we're sometimes reluctant to intervene in what we consider normal life process is, because we think that by interfering that we're taking away the body's ability to do it on its own. But in truth, for some of our kids, this may be their best chance to having an opportunity to be able to do this later on their own and under their own power. So at this point, I'd like to open this up for questions. If I don't have the answer to your question right now, today, then I'll ask you for your email, and I'll look it up and I'll get back to you. So please, I look forward to your questions, and I'm waiting.
Okay, I'm going to start unmuting people, and then if we have any feedback issues, then we'll do it one by one. But before I do that, I have one question from a woman who had to leave, but she wants to listen to the recording later. And she says that her son is 16 months old and has been on Miralax for 6 months. We were supposed to be able to try to wean him off this month, but it seems he's still having some problems with constipation, even on the medicine. So how do you feel about lengthy time taking Miralax, and do you have any suggestions for weaning? He takes about a half capful, she says.
I love Miralax. It has been a savior for many of the clients that I work with, where this has been, you know, the last best gasp, and it's done a really great job for them. This is a process that takes time. So he's been on it for 6 months. I think that as I don't know all the other issues with the child, but as he increases in strength and mobility, not necessarily just talking about walking, but as he increases in his mobility, his amount of movement, he will be able to wean off. It may not be total. It may not be total wean. But again, the issue is if we allow the bowel to remain distended and keep getting backed up and keep getting full of poop, then the opportunity for it to regain its original shape and strength is diminished. Okay. So it's, I'd say, be patient, and definitely be working with, if he's not currently receiving therapy services, with an OT or a PT, something to really work on some of those core muscles, that would be something important to add to the mixture.
Okay, great. And I'm unmuting others too. So please go ahead and ask your questions now of Hope.
I'm not hearing anything.
Not hearing anything yet either myself. Does anybody have any questions for Hope? Oh.
Hello?
Hello?
This is Lisa Schroyer. I've been to some trainings about constipation with pediatric palliative care doctors, and something that they talk about is sort of mush and push. So, you know, some things do the mushing part and the other do the pushing part. Does that make sense to you? Or do you understand what they mean by that?
No, I don't.
Yeah, I'll mute.
So mush and push?
Right. Some treatments work to soften the stool, and then other treatments work to help with the muscles, I guess.
Okay. Yes, I understand that. So the mushy part would be things like lubricants, stool softeners, mineral oil, things that help to soften the stool. And then the pushing would be the laxatives that actually have a stimulatory effect and help to push the stool through the system. So those would be things like lactulose, not one of my favorites, in fact, highly unfavored by me. Miralax, very cool medicine, very happy it came along. Dulcolax, which I think is very harsh for children, and I don't typically recommend it. So I think that's what they mean by the mush and push, is that sometimes kids need a stool softener or a way to soften the stool in addition to a way to push it out. Did I answer your question?
Yes, and I think, I guess in terms of considering what to do, I mean, if it looks like this is hard, I would think that you'd need to mush it versus pushing. I guess, going back to the goat turd.
Yeah, I agree. I think, so that's why one of the first things that I look at when I hear about goat turds in particular is I look at the child's fluid intake and the sources of fluid in their diet, because we tend to think just about water. We think water will fix everything, and we have kids, I work with kids, where water is absolutely not passing their lips. They're not going there.
Yeah.
So
finding... I'm working with families who have G-tubes so they can easily compensate by putting more fluids in.
Yeah, so I think adding more fluid to the mixture is really critical. And in some cases, I see parents who are apprehensive about giving more fluid because they haven't been given permission. They're told to put in a can of whatever, and then, you give a flush of 30 cc's. And so they give that 30 cc's and not 1 cc more because they haven't been told that they can provide more. And I'm a strong believer in, at least, 60 to 90 cc's of fluid with a can of supplement like Pediasure. 15, 30 cc's is nothing, absolutely nothing. And if parents see that their child is having dry stools, if they're looking dry around the mouth, or I tell them, give them some more fluid. I mean, water passes through our system pretty easily. So unless it's a child who's got some issues with fluid retention or maybe are on cardiac medications, because of fluid buildup, then I tell parents to be very liberal with that.
Yeah. Our gastroenterologist also gave us the formula for the parameters of fluids, based on height and weight. And that really gave us some more confidence in, what to give at least.
Well, I'm glad that they did that. I wish more people would do that and give parents that freedom.
I have a question about suppositories. If a child's, you're always waiting, my daughter's bowel movements are very erratic. So 1 minute she's not good, has very loose bowels for like 2 or 3 days, is pooping 4 or 5 times a day, and then all of a sudden she's constipated for days. And so it's hard to use the Miralax on a consistent basis. So sometimes we don't. We just use suppositories. And I was wondering what you're thinking on that, Les.
Well, suppositories really only work from the bottom. And so if you've got a backup at the top, you're not really affecting that. And I've seen kids on X-ray where the entire colon, quite literally, is just full of poop. Pretty amazing sight. So I'm not all that fond of suppositories, just because having a bowel movement doesn't mean that it's a complete bowel movement. You're just getting kind of the tip. Now, for some kids, that's enough. That's enough where they can now move things, because the hard, dry part is gone, and now they can move the rest through pretty easily. So, I mean, you know your daughter pretty well. So do you think that after a suppository that you're getting, a full BM after that?
God, I hope so. If not, there's a lot that, no, I think we are. My concern is always, is it hurting her to give her a suppository, let's say, for a couple of days, and then not for, it's usually that's what happens is we give it to her maybe 1 or 2 days, and then we don't have to give it to her anymore for a while.
And are these medicated suppositories or just glycerin?
I don't know what it's called. Duca?
Okay, so these are medicated suppositories.
Yeah, I guess.
Well, the glycerin ones, they're just lubrication, and they go in and then they slide out. I don't think that you're doing harm, and I think it would be more harmful for her to have the hard, painful poops.
The problem with the Miralax is we use it for a couple of days, and then the next thing is she's starting to have diarrhea, so then we have to stop.
Have you tried titrating it? Just kind of cutting back a little bit? I have families who use it every other day as opposed to every day because they had that same experience. Once they got the bowel clean, then using it every day meant that they were having lots of watery poops, whereas using it every other day, they were able to, affect formed poops.
Yeah. I mean, the thing for us, I don't want to take too much time, but the thing for us is that you can go for days without anything, and she's fine, and you keep going, and all of a sudden she has a lot of bowel movement. It's like her system is very confused, period. And so using outside things can just make it
worse.
Well,
and that's what I was talking about earlier in the presentation about some kids it's a lack or a diminished amount of movement of the smooth muscle, and in others it's uncoordinated, where they just, instead of it moving in a smooth, coordinated fashion, it just kind of blips all over the place, and so they, like your daughter, they have these periods where everything's going great, and then they fall out of rhythm.
Okay.
So
Thank you.
What you're reporting is not atypical. It's out there.
This is Lisa again. Sorry. My son's gastroenterologist really didn't like prune juice because he felt it was harsh and recommended that we use oil. What kind of oil that you can clean your just
What is
plain
it? Flaxseed oil?
No, just I can see what it is. It's clear oil that you can use on your furniture, and I just couldn't do that.
Mineral oil?
Mineral oil. It just really grossed me out.
Yeah, I'm not a fan of mineral oil. I have to tell you. And okay, his issue with prunes, it may be something that his parents did to him as a child.
Okay.
But when you think about dried fruits in particular, so prunes, dried apricots, dried cranberries, the way that they operate is that because they are so concentrated, you've taken all the water out, so now you've got this very concentrated glob in your system, and it draws water to it.
Well, I was using baby food prunes, so it's all mush and put them in seafood.
Yeah, I don't have a problem with prunes. I love prunes. I love dates.
I do too.
And I love pureed apricots, and I'd have to say one of my favorite things in the whole world is poop goop, which is made with basically reconstituted dried fruits. So you use raisins or prunes or apricots. I've even used pineapple, and you stew it in juice, and you add a little bit of smooth move tea, and you put it in the blender, and it does a really good job.
Wow. Okay.
And you know what, Tara, I'll send you the recipe.
Okay, great.
So I'm not quite sure what his issue is with prune juice. I would put prune juice in the same category as something like lactulose, where again you're using a concentration gradient to draw water into the gut and help move the passage of the food.
Okay. Thank you.
Anything else?
Any other questions?
I also know of a family where their son's infection is so bad that they have manually de-impact him. I think they've tried everything. He's an adult now.
Oh, wow.
I think that's clearly rare, but
well, it's not as rare as I'd like it to be, unfortunately. And okay, you guys are about to get a little bit of a soapbox. I don't think that we take pooping as seriously as we should, especially in children with developmental disabilities. I think many times we look at it as the last thing to deal with. You know, we're working with seizures, we're working with feeding problems, we're working with so many other, you know, systemic challenges that pooping just becomes the last thing on the list. And I've seen children that I've been involved with suffer horribly because we haven't paid attention to that. If a child has a neurogenic bowel, meaning that there's no innervation, no nervous input going to the bowel, in cases like spina bifida, then yes, manual disimpaction is the route to go, because there's no way that you're going to be able to innervate that area. It's kaput, it's gone. Okay. In most of the clients that I work with, though, who do require this level of intervention, invasive intervention, in my personal and professional opinion, it's because we have put off the issue of constipation too late. And so now we have stretched that balloon beyond repair. It's never, ever going to regain that tone. And so now the only way to get it out is to dig it out. That's why when I have parents who are feeling reluctant to use medication or to use different kinds of interventions, you know, there's so many things that for many of my clients, these are the last normal things that they can do with their kid. You know, I work in our feeding clinic. Feeding's a big issue. It's fraught with minefields, and for some of my families, this is the last normal thing. The same thing with pooping. It's one of the last normal things that I can expect from my child, and now you want me to interfere with that. But the best chance they have of ever being able to have that normal experience is making sure that the bowel retains its tone and elasticity.
There's a comment from Victoria who says that Fruit Ease is a good blend of prunes, raisins, and dates, that she used to use it like jelly on her son's sandwiches, and you can buy it online.
Absolutely. I wholeheartedly endorse that.
And Diana, do we have you on audio? I'm not sure if we do or not. I know you have a question. Diana, can we hear you? Okay.
I'm not sure if I have a microphone. Do I?
Oh, yes, you do. There you are.
No, I think I clicked on that. I'm still trying to just take it all in. My daughter just got diagnosed with 1p36 deletion syndrome. So someone had sent this link, so I just I'm finding it all very interesting. So at the moment, I don't have a question.
Okay.
And what was your child's diagnosis again?
1P36 deletion. And we were having a lot of constipation issues, but right now she's doing a lot better, but I've learned a lot more today. And I know it's interesting because I know on the link I was sent, it says that you do cover growth. Right now she's really small. She's turned 2 in May, and we can't get beyond the 15-pound mark. She's been like there since before she turned 1. She goes up and down between 15 pounds. So at her last weight, she was on the lower end of the 15 pounds.
Well, the reason why I asked you to repeat the diagnosis is because I think I've actually worked with a child with that diagnosis here at CHLA. And yeah, growth was a huge issue for that child. And what we ended up realizing was that the diagnosis was actually the problem with her growth. And so we were looking for ways to optimize her intake. We had her on jet fuel, pretty much.
What is that?
Jet fuel is when you just take everything in your kitchen and you throw it in there to make them gain weight.
Okay, we didn't do that for a year like we do. We have we have this thing we bought called Polycode that when she was hospitalized because of failure to thrive, they prescribed to us. So we add Polycode, we add butter. We've been doing, adding, half and half to her food. And it's like we have so much and she eats. She just doesn't gain any weight. So I didn't know if I could still continue to add all the butter, add the olive oil, I add the Polycode. We add as much as we can to her food and just she doesn't gain any weight.
Well, and that was the experience that I had with the client here at CHLA.
We put cheese on everything, and then that's when the constipation got worse, so we stopped putting cheese on everything because, it made her constipation worse.
Where are you located?
I'm in Long Beach.
Oh, okay.
And I found this website. So like I said, we just got diagnosed on Friday, so this is a lot of it is making sense now, so this is all new. So when I saw a link to this webinar, that's why I had never heard of any of this before. So I'm just trying to just educate myself as much, and hopefully, now that we know her, no one really seems to know much about, none of her therapists seems to know much about her diagnosis. So I'm trying to learn and see what I can do for her.
Well, in the end, with the client that I'm referring to here at CHLA, we realized that this child was going to be small, and so we worked to optimize her diet. But she's never grown at a rate comparable to other kids. We track other measures on her. We look at her energy stores. So I measure her subcutaneous fat that's up underneath her skin to make sure she's got adequate energy stores, that she's got adequate muscle protein stores. But she is still very petite, and that's kind of our expectation, is that she is going to be petite. So
I don't know what to do for her to get beyond that 15-pound range. Like I said, she eats, we feed her, try to feed her glasses, and I fortify everything that I can, and we just don't get beyond, it's like I don't want her to be 15 pounds the rest of her life.
Well, my client is not 15 pounds. I mean, she has grown, but I can tell you it's probably 1/3 or maybe 1/2 the rate of a typical child. So
one of the things that, sorry.
Go ahead.
One of the things that my son had Costello syndrome, severe failure to thrive, growth curves below the 5th percentile, and actually we're building our own growth chart with the numbers, which is still a small number. But the most important thing that we kept watching was the head circumference and the body length ratio. So we kind of looked at the size in relationship to the proportion of the body rather than any growth chart, because he was just off.
And I agree with that wholeheartedly as well. So when the child has not read the same chapter in the book that we have, then we need to start reading whatever this child is writing. You know, your child is writing a new chapter. And so the growth expectations for your child is not going to be anywhere near what other people might experience. What I would encourage, do you have access to Miller's Children's Hospital?
Are you talking to me?
Yeah, Diana?
We were being seen at Chalk, but so right now we don't have any doctors at Miller. She went most of her care was at Chalk. And I don't know, maybe you might be able to help me, that maybe give me a good referral for, because when she got her diagnosis, they didn't really have any referrals. We have like a regular pediatrician who really isn't that helpful. I don't think she's used to dealing with special needs children. So I don't know, I didn't realize that you're in the area, but if you can, I can get some referrals to, you know, get some doctors that can maybe, you know, handle special needs, because we don't have any.
Okay. I think we can help with that.
I don't even have a dietitian. We did see one, not since the diagnosis. So I don't know if the information they gave us in the past, because last time I went to one, they said, "Oh, you're already doing everything I would suggest." So they didn't have anything. But they didn't really handle. They mostly handle adults. They didn't handle you know, children in her case much.
Well, I think I can help you with some referrals.
I would really, thank you. I really appreciate that.
Okay.
Great. I think that we should probably wrap up. Thank you so much to Hope. We really appreciate this. We've already had some people asking if they can write about this in their newsletter, so I'm sure we'll be getting more emails afterwards. And to everybody today, as a follow-up to this call, you're going to receive a survey by email that will help us keep this program going, so please fill out the survey for us. And if you have any questions, don't hesitate to contact us at Family Voices. And keep your eye out for the next training. And thank you again, Hope, so much. This was great.
Okay. Thank you for asking me.
Thank you, everybody.
Okay.
Thank you.
All right. Bye-bye.
Bye.